at all the conferences we have. This is a very, very popular session. I'm going to ask our expert physicians to please take their seats, and I'll give quick introductions. Please, come. Give a big hand for our medical advisors. And we have Dr. Bruce Ritchie from Canada, Dr. Teresa Caballero from Spain, Dr. Nick Rumash from Brazil, Professor Marco Ciccardi, Professor Conrad Bork, Professor Henrietta Farkas, Dr. Hilary Longhurst from the UK, Dr. Mark Riddell, Dr. Marcus Margot, and Dr. Osawa from Japan. And of course, Professor Zura will be sort of the moderator, so we have about an hour or so to get your questions answered, and I'll turn it over to Professor Zura.
Thank you, Tony. I, of course, have the easiest job. I just hand out questions, and these guys are going to have the hard work of answering your questions. So I have had the opportunity to look through the questions, and I can say that there are many very hard questions here, and not all questions have answers. But I think our panel is very well equipped to try to answer them. And the other thing that we want to do as we go through this is to invite people to stand up and ask the panel from the floor questions that you have. So I think what we'll try to do is do the first round of people having questions, and once they answer it or give the best answer possible, we'll open up the floor, see if people want to address questions to specific people, and then I'll hand out the next round of cards. And if I hand you a card that's already been asked, a question that's already been asked, just let me know and I will give you a different one. So with that, could I ask Bruce to go ahead and read the first question and give us an answer?
Thank you. Yes, this is a tough question. It's from Brazil, and it says, I know this subject is controversial. You never want a question that starts that way. We know that gluten contributes to inflammatory processes worsening. I have felt an improvement in the intensity and frequency in the crises with a 90% decrease in the consumption of gluten. Is there any studies related to the use of gluten in patients with HAE? And I can say in all honesty that I have no idea. But let me ask a question. Has anyone else noticed this in the audience? So everyone put up their hands if they think gluten makes their HAE worse. Well, there you go. So that's very interesting. It turns out that gluten, which is in quite high amounts in wheat, which is Canada's other product besides oil, is a protein, and it's one of the things that makes gluten such a good cereal crop is that in addition to the carbohydrates and starches, it contains protein. But obviously lots of people are sensitive to it. So that's interesting. I don't know, does anyone else know if there's any gluten research?
We've been interested in the role of diet. It's hard to answer in a disease like HAE, but I think that there's actually very little known.
Yeah, but it does raise another possibility for us. We're very interested in the sort of spotty incidence of angioedema symptoms, and particularly the symptoms and clustering of patients with HAE with normal C1 inhibitor around the planet. In my center, the people who pay for the drugs ask why I've got such a large concentration of patients with normal C1 inhibitor and angioedema, and whereas Calgary, 300 kilometers south of us, has almost none. And I think there are environmental things that may be important, and one of the things may be the gut flora. And of course, gluten has an impact on the gut flora, so it's something we're very interested in. And Mark Rydell and I have been talking about doing a collaborative project on that.
Okay,
so that's
great.
a non-answer for you.
Thank you. We'll give it to Teresa.
Well, my question is from a caregiver in Israel, and the question is, What is the fastest documented time of a throat attack to block airways? I don't know if I recall well. I think it's 20 minutes in a publication by Conrad Bohr. No? The quickest time that an attack comes to completely block the airway. So that is not the most frequent, but sometimes upper airway attacks can be very, very quick. So every patient has to have treatment available for these situations.
Okay, thank you.
My question is from Israel. Is it possible for C1 inhibitor concentrate not to affect an attack? Can you develop resistance? And is there a difference between the type 1 and 2? So there is no resistance, and the C1 inhibitor improves the attack, and it depends on the person. In my experience, the concentration and the response. I have few patients receiving, I don't know if this is the question, but receiving concentrate from, repeating it every 3 days, every 7 days, so they can keep even prophylactic in different doses. So there is individual response for this treatment. Difference between type 1 and type 2, I don't see any difference in these patients. They need to receive the treatment as well.
I just wonder, Conrad, you published a paper suggesting at one point that there may be people who are treating often with C1 inhibitor are needing more and more. And the question is that a chicken and egg type of phenomena, or do you feel like the treatment with C1 inhibitor caused a worsening of the disease?
We don't know that at the moment exactly. There might be a reverse reaction in some patients, that the number of attacks is increasing in some patients, in a few patients.
Right. And we see that whether they get treated with C1 inhibitor or not. So it's hard to know if there's a causal effect exactly. Okay. Thank you.
Okay, the question which I have is about the possibility to test for C1 inhibitor for HAE, assume with normal C1 inhibitor or unknown HAE, and if there is the possibility for an accurate diagnosis. So far it's clear that there is no testing for these types of angioedema. For the angioedema that have normal C1 inhibitor, there is the possibility to identify some different mutations that have been described, and there are two types of mutation, one on plasminogen and one on angiopoietin 1. And these are the three diagnoses that can be made to avoid to use the term of unknown. Then there is the possibility to define, for at least in an approximate way, if the disease is inherited or not based on the family history. Having said that, there is not other possibility to further define the type of the disease that some people has. What is extremely relevant on this is to use at the best the clinical characteristics of the disease. And so at least to come up with one of the diagnoses that have been reported in the classification that there is of these other forms of angioedema, in order at least to be able to use some of the therapeutic tools that we have and that we can use, and at least start defining this disease in a little better way. But there is not, the test is something that still has to come.
And I would say that there are a number of labs around the world working to try to build that type of test. So, I think that the future is hopefully going to be better, and maybe next conference we'd have an entirely different answer.
I have an extremely interesting question coming from Finland. How will it be treated in future for HAE3 treatment? HAE3 is the same as HAE with normal C1 inhibitor. That means it's a heading for a title for several forms of HAE with a normal C1 inhibitor. And I must admit, we would be glad if we have a good treatment at present. And so it's not so easy to say what will be in the future. We don't know whether the different types have also a different response to treatment. That could be. We know that or assume something about the pathogenesis, that the factor 12 is involved, and the kallikrein is involved, and the bradykinin is involved to a certain degree or heavily involved. So we can use more or less all these treatments. We can use kallikrein inhibitor blocking or C1 inhibitor concentrate. We can use the bradykinin B2 receptor blockers. The experience is low, and of course there are no studies about that, and what will be in the future. If it turns out that in certain forms the kallikrein inhibitors are more valuable, then this will be perhaps the future treatment. At present, it is the impression that the frequency of attacks is not so high, so that the prophylactic treatment is only in the few patients necessary of this group. There is one exception. This is the angiopoietin mutation. This has a different pathogenesis, much lower, and at present we have no idea whether the normal treatments we use in the other types is working at that.
Thank you. Henriette?
My question came from a US patient. I am controlled HAE patient on progesterone. How does progesterone help control HAE, and why doesn't it work for everyone? So it is well known that estrogens may provoke attacks. We don't know exactly the mechanism of this effect. Maybe these drugs decrease the activity of aminopeptidase, which plays a role in degradation of bradykinin, or effect on factor 12. We know that in normal C1 inhibitor function HAE, factor 12 plays important role because it includes estrogen sensitive element. Progestins is anti-estrogen, has an anti-estrogen effect. And so estrogen-containing oral contraceptives are not recommended for HAE patients, but we should try progestins. We have 2 patients on progestin anti-contraceptive treatment. They tolerate it well, but we didn't observe any changes in their attack frequency. However, we know that it was published by French colleagues that progestin not just a good anti-contraceptive treatment, but it would be a prophylactic treatment as well. We hope that some patients will experience decreased attack frequency. But I cannot say what is the reason that this patient respond to this treatment well regarding the HAE severity, and other ones no.
Yeah. And the French say a lot when they talk about the effect of progestins that they have stronger antigonadotropin-type progestins and other synthetic progestins at least compared to the United States. And whether that has any role to play, I don't know. Mike Frank also says that in type 1 and type 2, he saw no beneficial effect. I think more people have seen it with the HAE normal. Yeah, for normal, yeah. Okay, thank you, Henriette.
Okay. So my question is from the USA, and it's an interesting one. It says, what is your opinion on pre-implantation genetic diagnosis to have a child without HAE? Now, as you know, if one of the parents has HAE, there's a 50% chance that the child will also have HAE. And certainly, if you know what your genetic mutation is that's caused the HAE, it's technically possible to have pre-implantation genetic diagnosis. So this is IVF. It's expensive, it's quite emotionally traumatic, and there's a certain amount of time and quite a lot of money that needs to be invested in it. But the UK, certainly, and I think European countries, will often provide pre-implantation genetic diagnosis for inherited diseases, and this is a financial decision made on the basis of the amount of money it might cost to treat someone with bad HAE for a lifetime. Of course, what you have to decide as a parent is very difficult, because we can see that we're going to have a better future, so you have to decide whether what you have to go through to get a baby by IVF outweighs the knowledge and the satisfaction of having a baby who you don't have to worry about HAE or their health in that way. So this is a very personal decision. The other thing I would say is that if you want to think about IVF isn't always successful, even after several attempts. But if you want to do that, it's better to do it while you're younger, and ideally while you're still in your 20s or early 30s, then you would have the best chance of success. But of course, IVF is getting better, so it is possible to have a success, at way older than that.
Yeah, and I think Marco has made the point that I agree with, that there are a lot of differences between people. We all have our individual variations, and we don't know what has other beneficial effects. And as HAE becomes treatable, it's not necessarily something we should think of as a terrible problem. Mark.
So at first I thought I got lucky because I got a very straightforward question written on this card. And then I quickly realized I don't know the answer to the question on this card. And so I'm probably going to ask for help from someone else. And believe it or not, it may be someone who's not on the panel here. The question is, where will the next HAEI conference be? I'm getting shrugs from the leadership over here, from Henrik and Tony, so I don't think we have an answer to that right now.
I think I'm going to put you on the spot
You're
and
give
another question.
Right. I thought that might happen.
I can do that because he works with me.
All right, so off the cuff. Are there studies involving HAE with normal C1 inhibitor and low C4 as a in parentheses here, also clarifying the scientific diagnosis of HAE with normal C1 inhibitor? So insurance will recognize the diagnosis any closer. So we've sort of covered this, I think, in some of the other questions. I mean, the studies on HAE with normal C1 inhibitor are really sort of two types. They're describing the symptoms of the condition and sort of comparing it to the other types of hereditary angioedema that are better understood, type 1 and type 2. And there are studies looking for the cause of this, which you've heard about some of this meeting. We have some families that unique mutations have been found, but we don't have a good explanation for most patients as to the cause of HAE with normal C1 inhibitor. There are no studies looking, or controlled studies looking at treatments, as I think you already heard from Conrad. So there are some descriptive studies in certain patients showing that some of these HAE medications work or don't work. And so I think, as we've talked about, we need to do a lot more research in this area. And I think it's sort of the next big frontier in angioedema, is to better understand this condition. As was noted on the card, we do have difficulty, certainly in the United States, getting treatment for people with this diagnosis, and that's one of the reasons we really need to have a diagnostic test so that we can sort of firmly establish who has this, which may make it easier to get treatment for people. And I suspect it's similar around the world, that it's not an easy task to get medication for people with HAE with normal C1 inhibitor.
Thank you. Marcus.
My question is from Mexico, and the question is there any special consideration to be taken in account when pregnant? I think yes, a lot. It's recommended to stop smoking, drinking, and all this stuff, but I think you refer to HAE. So first of all, one should be aware that the clinical picture of HAE may change. The literature is not uniform. The literature is a little bit divided. So one study say the number of attacks will quite likely increase. Other studies say no, it will not change too much, or even become a little bit better. So it's not absolutely clear, especially there can't made individual prognosis how HAE disease activity will develop during pregnancy. In my very personal opinion, I see that the majority of the women get more attacks after becoming pregnant than before. The number of attacks will change. If it has changed, the next point that something changes is delivery itself, and the next hormonal break in this event is stopping breastfeeding. So all these events can mark a point where changes happen, but it's not predictable which direction and if any. The other consideration, I think the most important, is about treatment during pregnancy. One point that's very clear, there is only one recommendation how attacks should be treated in pregnancy, and that's C1 inhibitor intravenous, C1 inhibitor to treat the attack. However, it has been shown many hundreds of times, especially in early pregnancies, that icatibant was given by not knowing that the woman is pregnant, and it has shown that the risk is obviously not high. The risk is very low. No damages has been reported. However, it's not a recommendation. Yes, I think that's.
Okay, great. Thank you. Please.
First of all, because of my unskillful English, so sometimes I need a translator. Beverly Yamamoto, help me. My question is it possible to die from a stomach attack? HAE patient would not die from a stomach attack, but would die from a misdiagnosed operation itself. It's my answer. Okay.
Okay.
Right?
Thank you. So, now we're warmed up. We've been through one round of questions. And what I'd like to do, you've seen us go through our paces. I think we have some microphones, hopefully, around the room. Yes? Raise your hand. I see lots of hands raised. And you can either ask any question and we'll go down the line, or if you have a particular person, you can address it to them. And let's just start some questions coming from the floor. I'll depend on the people handing out the mics, because...
Hi. To begin with, I'd like to mention, I forgot to mention one physician. I was thanking Dr. Karen Binkley, okay, for the HAE with normal C1. And now the question I want to ask is, I want to ask Dr. Borick, Dr. Ritchie, Dr. Rydell, and Dr. Chicardi. You've been doing so much with the HAE with normal C1, and thank you very much for that. Dr. Borick, when I spoke to you a while back, and I haven't seen any articles since, what about the ones who hemorrhage into their swellings?
So the question, if I heard you right, is it possible in HAE normal C1 inhibitor to hemorrhage into the swelling, to bleed into the swelling?
Oh yes, that's well known in one form with the factor 12 mutation, that there may be hemorrhages in swellings. This has been observed until now only in females. You know, there are also some males with the disease, but this has, we had such patients and looked for the coagulation parameters and all things, but we didn't find any cause for that. But it is known in patients, and this might be in any swelling of a patient, or at some time and there are pictures in the literature with hemorrhages, for instance, for the lid swellings and so on. So it's well known. The cause is unknown until now.
Would you recommend any of you, this is where we're ambivalent with my treating physician, is having had a sister which we lost from bilateral pulmonary embolus. But when they treated our hematological studies, which we don't easily access in Manitoba, we only hemorrhage during an attack, but I'm an hour and a half away to get these hematological studies, so I can't be in an attack for an hour and a half to get these studies done. And I do respond to C1, but not everyone from our family does. But they're ambivalent to try the tranexamic acid, because I had a low homeocysteine, but they figured it was from all the hemorrhaging. Have you guys had any experience with this, and would you have any recommendations to give?
The question was...
I didn't really, couldn't hear the question. Did it? And does anybody have an answer? I'm not sure what you were asking.
If it would be safe to try tranexamic acid.
The question was, yes, tranexamic acid is a good possibility for HAE with a normal C1 inhibitor. We have experience in patients with the factor 12 mutation, and it's working. At least it is, we have experience in a few patients, but for several years, and it was very, in the majority, it was very good working. It reduced the attacks practically always to zero. So it's a good possibility.
Thank you.
Okay, Bruce, you want to comment?
Yeah, I, in addition to treating angioedema, I treat bleeding disorders, and in my center, tranexamic acid is known as my favorite drug in the city. So it's a very, 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 very safe drug. People talk about thrombotic potential of tranexamic acid, but in all the large studies of tranexamic acid, it's not seen. And the cardiac bypass surgeons use it in huge doses compared to what we do clinically. So it's a very, very, very safe drug. There are issues with thromboembolism and angioedema in that C1 inhibitor in large doses can provoke thromboembolism, but tranexamic acid is probably very safe, and you could use it safely.
I have to say, do you really believe that C1 inhibitor causes thromboembolism? I have severe doubts about that personally.
Well, the studies were all done in animals. In the animal studies with large doses, they saw thromboembolism. And in our center, where our normal C1 inhibitor patients are treated by my colleagues with large doses of C1 inhibitor because my colleagues can't access icatibant, we've seen 4 patients with life-threatening pulmonary emboli, all young people on anticoagulants now, and we have no other reason for them to get these problems.
Okay, we have experience with a large group of normal C1 inhibitor patients, and we use tranexamic acid. And they respond in a different way from the patients with HAE type 1 and type 2, and with low dosage. So we don't use very high amounts of tranexamic acid. If they respond with a very low dosage to this. And so any of them, we are trying to compare the factor 12 mutated patients with the one that don't have this mutation, because we have also in Brazil a lot of factor 12 mutated patients, and it doesn't seem so different in this way, but we still are collecting the data about this. But very, very low with no problems, as you mentioned.
Okay, thank you. Do we have another question from the audience? Yes.
Yeah, hello. I come from Greece, and I have a daughter with HAE. I'm not a patient myself. And she's a teenager, so I wanted to ask how HAE affects a woman in her sex life.
How HAE affects a young woman
according her sex life.
In her sexual life, okay. Yeah. Who would like to answer this?
Well, as a mother of 3 young women who've just come through their teenage years, not entirely, my recommendation is that it's good you're thinking about this now, and it's good to discuss these things with your daughters early. Now, HAE, of course, can get more troublesome when the estrogen hormones start to get at a higher level during teenage years. And, of course, there are the usual stresses of being a teenager and boys and everything like that. I think that it's very, very important to discuss sex with your daughter. And I can tell you, your daughters will be, oh no, mum, don't say it, don't go there. But they have to hear it.
That's the case.
Yeah, they have to hear it. Yeah. And they have to know, apart from the usual things about sex, they have to know about contraception. And for hereditary angioedema, of course, they should, if at all possible, avoid estrogens. So that's the standard contraceptive pill. But they can take the mini pill, so progesterone-only pill, and this might actually be helpful to their hereditary angioedema. Some of my patients do find it helpful, others don't. And I think they should also know about the morning after pill. So if they had unprotected sex, then the pill that they take to prevent pregnancy is usually progesterone, so it's okay to do that. Yeah. And in most countries, a young person won't tell their mother. They will go to the pharmacist, or they will go somewhere who maybe doesn't know, so that child should, or that young woman should know already. Okay. And of course, sex and boyfriends and everything is a very stressful, very exciting time. So I think the things that we would want to do as a parent to teach our children to have respect for themselves and others and protect themselves and make sure that they have self-esteem is also really, really important.
But what? Thank you.
So let's also discuss, though, when a young woman does become sexually active, there is the risk of having genital swelling as a consequence of having intercourse. And so what would we tell a young woman about that?
Yeah,
I'm just asking the question.
Well, I think for all our children, we need, if they have HAE or any other potential problem, even if they have no symptoms to start with, they need to know how to deal, ideally, with any eventuality. Because if they're a teenager, they might be on their own when it happens. They might not have anyone they can talk to. So, of course, a gentle swelling, very embarrassing as it might be, is the same as a swelling in the hand or anywhere else. It can be treated. Hopefully, before they enter teenagers, they will know what to do if they have a swelling. It's better to treat it earlier rather than late. So I think it's something to discuss with them specifically and make sure that they're prepared.
Thank you. Oh. Go ahead. Did we not answer the question?
Sorry. I tried to put it in words, but maybe it's not the doctors, but the other patients, because I don't, I'm not a patient myself. What are the implications? How they psychologically, how this affects their expressions. I don't know if
How does the HAE affect the psychologic impact of puberty on children?
Yes.
I think all you can do, I think there's two things. I think when young people are prepared for puberty, then puberty is always a little bit difficult,
Yes.
but maybe it's a little bit easier, and everyone has their own challenges to face, and if you have HAE, that's one more challenge that you can help with by preparing them. The other thing is maybe they should come to the HAE International Youngsters Group, because I'm sure they're talking about sex, amongst other things.
Thank you, Hillary. Okay, do we have another question from the audience?
Yes. Hello, I'm from Croatia. I have one question. I was watching Dr. House episode about HAE, and there was a patient with brain swelling. So is it possible, and is it life-threatening, and what to do in this if is it through brain swelling?
So that's the question, as I understand it, is does HAE potentially cause swelling of the brain? And if it does, how would you treat it? Henriette.
Thank you for your question. We have some patients who had frequently a headache, which does not respond to the common treatment, analgetics. And we recommend this patient to use C1 inhibitor concentrate during these symptoms, and it worked. So unfortunately, we didn't have any chance to make a MRI during this episode because it is very short, come and go. So we cannot prove it by imaging, but based on response to the HAE treatment of these symptoms, we suppose that it was caused by HAE.
Mark, do you want to make a comment?
I was just going to say that I also have taken care of a number of patients that report headaches, sometimes very severe headaches, either with their attacks or at other times. And there is, as I understand it, there's a little bit of data to suggest that bradykinin may play a role in migraines. As Henriette said, I'm not aware, I look into this periodically because the question comes up so often, I'm not aware of any documented cases where imaging has actually shown brain swelling, where you can visualize the actual tissue swelling, but increasingly, it's just my impression, I do believe that headaches may be part of the syndrome for some people. I don't know that it's dangerous. I've never seen complications from it, but it may have something to do with the contact system activation in HAE.
Yeah, the closest I've heard of, I haven't witnessed it myself, is Dr. Nielsen from Norway wrote a paper once where he described TIAs, transient ischemic attacks, like mini strokes that appeared to respond to C1 inhibitor concentrate. Conrad.
I have several patients with headaches, and they have severe headaches, and all of them are patients with many attacks with the severe form of HAE. And they told me their experience that they migraine-like symptoms, not identical with migraine, but there is an overlap, that they responded to C1 inhibitor concentrate for acute treatment, and also for prophylaxis on danazol. It's more than 10 years ago. But it was very clear, for them it was very clear, and for me there's no doubt there is a certain involvement. The problem is the overlap, which was mentioned with migraine, and now the research on migraine is focusing partly to the role of bradykinin and also for the treatment with which we use for bradykinin angioedema. The neurology is at the moment focused on that.
Okay, thank you. Any other questions? Yes? Don't know where the microphone is. Okay.
Sorry. My name is Anne. I have HAE type 1. I often suffer from migraines. The doctors always say that they're migraines. The minute I infuse, I feel a lot better. My question is, my pain is always there until the swelling is fully gone, and mine have been tracked. But is there any documentation on medical marijuana if it's taken the pain away? Is there anything else that could be given for the pain? The swelling is going away with the C1 inhibitor, but the pain is my most traumatic thing.
Anybody want to try answering? Bruce, brave man. We won't tell Mr. Trump what you're going to say.
So some of you may know that marijuana is being legalized in Canada, not just medical marijuana, but marijuana for recreational use, so come to Canada. But, and it has been available for medical use for a while now. Many physicians don't like to jump through the hoops of making it available for their patients because there's many forms to fill out and things like that. But I have a number of patients who have agreed that it is beneficial to them and it helps their symptoms, both the swelling and headaches. So I've heard that a number of times. Haven't had a chance to try it myself yet. I would like to comment just on the last question, though, about the neurologic involvement with HAE. We have a patient with HAE with normal C1 inhibitor who gets unilateral, so one-sided blindness with her attacks. And we've done MRI scans and have never been able to show any angioedema in that patient. There is a technology called visual evoked responses where you can shine a light into the eye and look at the back of the head for an EEG signal, and we haven't been able to get the timing of that right because it's done at another hospital. But you know, just going back to the neurologic association, I think it's very intriguing, and I think there's something there.
I have gone through MRIs and CT scan for my brain swelling, and with my swelling occurring like this, like I said, for medical marijuana, but is there anything else that you guys would recommend for the pain? Because I don't want to continuously take medication that's going to ruin my liver, my kidney. My health matters, right? So that's another part of it as well. Is there anything else that you would?
Well, what I want to say is really like a migraine patient, myself. I think that migraine is also very, very common. So maybe that some patients had both diseases. So we should have that into account. Although I also visit patients with migraine during the attacks, I also have patients with long-lasting migraine or cephalea, and I've done all types of imagings. I haven't found anything, but I think that then you have to go to the neurologist, and there are a number of treatments for prophylaxis of migraines. And as well as we are saying that we have prophylaxis for HAE, we also have prophylaxis for migraine. So you don't have to wait for a migraine attack to come.
Okay. Do we have other? Yes, please.
Hello. This is less of a question about the mechanics of HAE and more of a question about the relationship between patients and doctors. Many HAE patients have been in situations where they're seeking treatment for a severe or episode, so laryngeal or abdominal, and the physician that is responsible for them is not understanding of HAE and is hesitant to listen to the patient. So as doctors, with your knowledge of how doctors think, do you have any suggestions for patients when it comes to communicating with physicians who don't understand or who don't want to try to understand, if that makes sense?
I usually recommend my patient to bring the patient info card with them and the last hospital notes or outpatient clinic notes. And this card included my cell phone. I am always available for them. And if the physician doesn't want to administer the appropriate treatment, just want to choose corticosteroids and others, I ask the patient to call me immediately, and I usually discuss the patient case with the physician, and it is a good solution for this problem, I think.
This is going to sound like a glib comment. It's not meant to be, but my short answer to that is find another doctor.
You're definitely right.
That's not always possible, I understand that, but I heard something very important that the patient, I think it was the Sub-Saharan Africa group, it only takes one doctor to really be your point person, and that's part of the reason we think it's very important to find an expert, whatever that is, in HAE. It could be your family doctor, it could be your pediatrician, it may be an allergist, it may be a hematologist, but someone who's interested and willing to learn, willing to have you teach them what it takes to take care of this condition. And then that person can really work with you to communicate to those other people, your surgeon, your gynecologist, your whatever else it is, the emergency room if you have to go there. Unfortunately, there are physicians that will just not listen to you, and that's sad, but that's the truth. They may be willing to listen to a doctor who's working on your behalf and working with you. So my advice, find that one person who's willing to go to bat for you, work with you, and then the rest of it gets easier most of the time. That's been my experience.
I found that the skill of self-administration is very useful to avoid these situations because many patients know much more about the disease than the doctors they are facing. And why to teach first the doctor to give a treatment if you have all the education and the only thing you still need is the skill for self-administration. So I think I would focus on this, and this would solve a lot of problems.
Not to be too hard on my kind, but that's almost a risk factor that when you know more than your doctor, they almost resent it if they're that type of doctor. And so I would agree with Dr. Rydell. Okay, do we have other questions, or should we do, oh, yes, we have an eager question.
Hi, I'm from America. So I had a question about laryngeal swelling and your opinion on, a lot of doctors like to see the swelling, and sometimes with laryngeal swelling, it's on the inside. So they always want to put a tube down your nose to see the swelling. And every time they do that, they poke it and it makes it worse. And I've been intubated 3 times, and they don't want to listen to me when I say I have throat swelling. They always want to see it. So I always refuse. But what is your opinion on actually doing like an endoscope to actually see the swelling objectively for the doctors?
I think there is not real need for the doctor to check if there is the swelling or not. Checking a swelling in the larynx is difficult unless we have a laryngoscope. It's totally impossible. So you don't have to look for the swelling in order to treat. Whenever you have the doubt that something is going on the larynx, you just have to treat, no matter if it is present or not. There is no other question. It's totally useless to find the swelling.
What?
And you don't want that delay, right? We don't want a delay. If we're dealing with throat swelling, the sooner you treat,
the only
the better.
thing you can do is could make it worse.
Yeah.
If you don't have a good practice in doing laryngoscopy, you make it worse. And there is no disadvantage of treating. Even if you don't have the edema, there will not be a problem if you treat it. So when you weigh the 2 opposite conditions, it's definitely better to treat and nothing else, and that's what the doctor should do.
Okay. Let me just ask a specific question. In the Japanese contingent, does anybody want to ask a question, even in Japanese? If you're inhibited to ask questions in English. Is there anybody who wants to ask a question in Japanese? I speak it fluently, by the way. Okay.
Can the HAE patient take headache medicine? Headache medicine? Japanese. Sorry. HAE 患者は頭痛薬を使うことができますか?
See?
His question about HAE patient can use headache drugs. Okay, headache drugs. Okay, you can use that.
So we see patients, some types of patients with angioedema that can be caused by aspirin-like drugs, but HAE is different than that, and there should be no problem. Okay, looks like we have about only 12 minutes left, and would there be an objection if we do a speed round? Because I think everybody has a question that they've been holding for a long time. So if that's okay, why don't we just go around and do the next round of questions?
There's one in the front here.
Oh, sorry.
Thanks so much. I wanted to ask you, can we have, in simplest terms, an explanation of where the error in the genome and the DNA is or are for all the ills we see here? You know, in simple terms where we can all understand it.
I can answer that. The answer is no.
That's as simple as you can get. Thank you.
I wish it was simple, but as we've heard, there's the many genes involved in many different positions and many different mechanisms. And we're trying to understand it all at present.
But there's certainly no simple answer to it.
Any closer information than that?
No. I mean, there are 4 different genes that have been identified, and there are probably more. There's multiple positions in some of the genes, so it's very complicated. And there's probably disease-modifying genes as well, so there's combinations of genetic changes that are probably going to be important. I think, is that a fair comment?
Yeah, and we don't know that aren't epigenetic changes that are important in disease manifestation. So the complexity becomes overwhelming.
Okay, Bruce has given me another unanswerable question. So he's big Bruce, I'm little Bruce. So instead of just answering this, I'm going to go back to one of the previous questions about doctors not listening to their patients. In Canada, HAE Canada has come up with a wallet card that we give to all of our patients, and it says what the standard treatment is for these patients, and it gives the contact information for the doctors, and we ask the patients to pull them out when they end up in the emergency room or seeing a doctor that's not familiar with HAE, and when the doctor they're seeing does not want to call us, I then tell the patient to call us directly. They page us through the paging system. And what I will do is phone the emergency room or the doctor and say, hey, I hear you've got one of our patients there and you probably need a little help. So this is what I think you should do. So I think those wallet cards are very useful. And I'm just, I'll ask the HAE Canada contingent, are they willing to share that card with HAEI? It could be used globally and translated. I see some nodding of heads.
So I think many countries, hopefully all countries, the patient organization is working with the doctors. Everybody should have these cards. They are an important part of management. And probably everybody up here, our countries have these cards, right? Sure. So we would urge you, if you don't have it, to find out why and have this for the good of everybody in your country.
Okay, so the question is from the UK, or the United Kingdom, or disunited kingdom these days. Although they're united behind the marriage of Harry and Meghan today. And the question is there any link between angioedema and vasculitis, particularly anti-C1q induced urticarial vasculitis with angioedema? So very complicated question. And I think we've heard today and yesterday from many people saying that we like to categorize angioedema into that caused by bradykinin and that caused by allergy or histamine-based mechanisms. But there was a very good talk a few years back by Avner Reshev from Shalom University on the overlap of the 2 conditions, which makes it very difficult. We do see hives occasionally in patients with clearly diagnosed angioedema. So to say if you have hives, you can't have C1 inhibitor deficiency is untrue. And so it's complicated. And I think Marco in particular was talking about other types of capillary leak syndrome and other types of swelling that's sort of a final endpoint in probably many different mechanisms. So is there a particular link? I haven't heard of one in particular. I don't know if anyone else has, but Hillary does. So I'm going to pass the microphone for this difficult question to her.
So when you have C1 inhibitor deficiency, you have low C4, which is one of the blood tests we do for diagnosis. And when you have low C4, you don't regulate your complement inflammatory pathway very well. So I believe that for this reason, you're slightly more likely to have what we call urticarial vasculitis, which is a skin vasculitis, not usually serious, but obviously troublesome and maybe can be mistaken sometimes for HAE if it's a big swelling. And I've certainly seen it in a couple of my patients. And it responds very well to hydroxychloroquine. if it's troublesome. But probably the best preventative is to control your HAE well, but obviously that's not always possible. Oh, his...
I know you have nobody in the audience answering a question, but I'm Alan Kaplan. I think the person who asked the question is concerned about what's in the literature. See what the urticarial vasculitis to which you are referring has a circulating factor that binds C1q, but it is not a factor that binds C1 inhibitor, nor is it C1 inhibitor. So they sound alike. But the urticarial vasculitis mechanistically then is a cousin, but the manifestations are quite different.
Yeah, they are. But Hillary's point is still fair that in Chaim Brickman many years ago in the mid-'80s published back-to-back papers in Mike Frank's group showing that there's an increased incidence of a number of autoimmune and inflammatory diseases in people with active HAE. So I think both answers are correct.
Well, my question is again from Israel, this time from HAE patient plus a caregiver, and they ask, my attacks develop to maximum in a few hours. Is it safe to rely on this pattern regarding carrying the meds? Well, I think that you cannot rely. You have to carry your meds with you. When you go to work, when you go to study, I think you shouldn't leave your meds at home. It's the same message that we say to our patients with anaphylaxis and adrenaline. You have to keep your drug with you.
Yeah. You hope for the best, but you plan for the worst.
Oh, my question is from Australia. It's an interesting case. It's my daughter's HAE is out of control. She was born without a thyroid gland, and this is managed with bithyroxine. Her HAE attacks get worse during her monthly cycle. And this is the question. She is 32 years old, is considering a hysterectomy. Do you have any advice on this? Yes. Don't do it. Yeah, of course. You know, I have received, I'm surprised, but I have some patients that suffer from different surgeries like hysterectomy in Brazil and ovulectomy. So it's swelling, take it out. So I wouldn't do it. We talked about progestin or contraceptives. It's possible to use, even people without HAE use continuously contraceptives. So it's possible to treat. And even the attacks, I wouldn't take it out, you know.
Thank you.
Okay, I have an important and simple question, which is about the shortage in C1 inhibitor that has been faced at the end of the last year in Europe, but also in US. And if there is any strategy to mitigate or to prevent anything happening in the future. And of course, this is more for the companies, but I think I can assure that strategies have been put in place and they are advancing. Producing plasma product is something that needs time in order to adapt the places where these products are produced, so it cannot happen within a few months and even within 1 or 2 years. It takes a long time to get new plant ready. The C1 inhibitor has changed the indication because there was a limited indication in the past. Then now there is a very large indication, but the companies that are making plasma products, they are improving and increasing the plants, so I don't think that this will be a problem for the future.
Great.
I have a question from Australia. I am HAE type 1. When presenting with the laryngeal symptoms to emergency room, I have been told a normal C4 level rules out my symptoms as being due to an HAE attacks. Is it possible to have a normal C4 during an attack? It's an interesting question. The C4 is usually low, as you know. There is a very small possibility that C1 is normal, but not during the attacks. During attack, the C4 should go down, but in any case, an ER is not the right place to talk about the diagnosis, about laboratory, so it has been checked after this event within the next time.
And I'd say that while there's a theoretical possibility that complement wouldn't be involved in an attack, in all practical circumstances we've seen, it is involved, but C4 levels are very, very variable across the population. It's a very wide range. And so it'd also be interesting to know what the starting C4 was, because it may have fallen, but still not be really low.
I received a question from Laura from the United Kingdom. I sometimes hear patients have dramatically increased their use of medication because their attack pattern has suddenly become more frequent. It then turns out that this is caused by another underlying condition, for example, infection. Would you recommend any alteration in attack pattern should be reported to and discussed with clinical team? Thank you for your question. I think it is a very important question, and I think it is the reason of the regular follow-up of our patients and and contact them regularly. We published many concomitant diseases which influence the severity of HAE, just picked some of them up. Celiac disease was one of them, vice versa. So we had a patient with celiac disease who was diagnosed with HAE because the diet was not effective, and finally the diagnosis was HAE, and their abdominal symptoms were related abdominal attacks of HAE. And we had a patient with Crohn's disease, and when his Crohn's disease was flare up, his HAE symptoms became more frequent and severe, and very common thyroiditis, Hashimoto thyroiditis, among the female patient in Europe, and we check our patient for the function of thyroid and antibodies, and so finally, when we found the underlying or concomitant disease and we treat this disease, HAE improved. Another issue is the infection. So the chronic, we should focus to find a chronic infection like chronic tonsillitis or sinusitis, and we should eliminate these diseases. And the acute infection also important, especially in pediatric patients, because during upper airway infection, the laryngeal attack may occur more frequently. Vaccination are recommended for all patients. It is a frequent question from GP that they can receive vaccination or not. And another type of diseases, the autoimmune diseases, which was mentioned by Professor Bruce Zurav. We conducted a study and found that 11% of the prevalence of autoimmune disorders among HAE patients compared to healthy subjects, in which was 5%, but it was not significantly higher.
Okay, well, I've got a duplicate question. So instead, I'm actually going to come back to two previous questions. The first is the one about whether you can become resistant to C1 inhibitor treatment. And there is an exception. If you have acquired C1 inhibitor deficiency, then usually C1 inhibitor is a good treatment, but occasionally you can become more resistant and need higher doses. And in that situation, of course, we have icatibant. And my impression, and maybe there's a teeny weeny bit of data to support this, is that icatibant is possibly even more effective in acquired C1 inhibitor deficiency than in hereditary. And my second comment is for the lady who has the chronic headaches. And I often see people with chronic pain who've had very bad hereditary angioedema, and usually it's chronic abdominal pain, and it does respond to C1 inhibitor. I don't know about the cause of the pain, but if you're from America, you have HAE, so you have the possibility to put your C1 inhibitor back to a normal level, and maybe you should speak to your physician about the possibility of trying that maybe for a period of time to see if that improves your headaches before you think about other pain relief.
So I have a question from the US. Do you know of any connection or similarity between HAE and Guillain-Barré? Those of you who don't know, Guillain-Barré is a neurological condition, more chronic symptoms that can sometimes be progressive, that results in weakness, and usually the legs, but sometimes the arms. And it really results in motor symptoms, difficulty moving, and in very rare cases, paralysis. So I think the symptoms of HAE and Guillain-Barré are quite different, largely. This is Guillain-Barré being a much more chronic, long-lasting condition. And I'm not aware of any connection between the two. I think neurological complications from HAE are rare. You've heard about a few of them here, headaches potentially, visual changes in rare cases, TIAs perhaps. But I'm not aware of any connection with Guillain-Barré. I don't know if anyone else feels differently. Okay.
A question from the USA. How can patients with C1 inhibitor, with normal C1 inhibitor HAE or HAE unknown contribute to ongoing research in addition to a contribution to registry? I think I've heard about the big interest you have in HAE with normal C1 inhibitor, and the interest is the same on the researchers and the physician side. So many researchers and physicians are highly interested to win insights into these HAE unknown, and many big centers and small centers are doing research. So if your own doctor doesn't offer you a participation in a research project, I suggest to get in touch with a national patient organization, maybe with an international patient organization. That could be one address to get information, and the other one is check the closest specialized center to your site. In the US, you have the center in San Diego. Other well-known sites are known in the countries, and ask the physicians there if you can participate in bringing light into this dark chapter of HAE.
And last but not least.
This question from Mexico, HAE patient. Can previous chemotherapy have a bad interaction with present HAE drugs? I have no evidence, but tumor cells activate a complement system, especially in a classical pathway. So C1 inhibitor consume, so HAE attack may increase. So.
Okay. Well, thank all the members of the panel so much. Thank you for all your questions. I did not nearly get through all of them, but I'd say that everybody up here would be delighted to answer them either later on this evening or by email. This is our passion. We want to help, and so please reach out. And again, thank you for your attention.